Welcome to This Explainer. Today, we are dissecting one of the absolute most critical and, frankly, most challenging aspects of our clinical practice, pediatric procedural sedation and analgesia, or PSA. We'll be doing a deep dive into the latest evidence, pharmacological profiles, and safety guidelines to equip you with the absolute gold standard of care. Because, as we all know, children are not just small adults. Their physiology, their rapid hemodynamic shifts, and their profound anxiety make them a uniquely complex population to sedate safely.
Hello, pediatric anesthesiologists. Thank you for your hard work today providing on-site pediatric sedation. Today, I will review sedation for pediatric patients, who constitute the most challenging patient group among all types of sedation.
Halo para ahli anestesi pediatrik. Terima kasih atas kerja keras Anda hari ini dalam memberikan sedasi pediatrik di tempat. Hari ini, saya akan meninjau sedasi untuk pasien pediatrik yang merupakan kelompok pasien paling menantang di antara semua jenis sedasi.
Right, here is our clinical roadmap for today. We'll start with the core principles, move through assessment and fasting, tackle the pharmacology and monitoring, handle adverse events, review safety guidelines, and finally, lock down our discharge and quality improvement protocols. Let's get straight to it. Section 1. Principles of Pediatric PSA. So, what are we really trying to achieve with pediatric PSA? It's far more than just keeping a child physically still for a scan or suture. The true goal is multifaceted. We must alleviate pain, massively reduce fear and anxiety, completely minimize psychological trauma, and ultimately ensure the safe completion of the procedure. And what's truly fascinating and demanding for us as clinicians is how rapidly this practice is expanding beyond the highly controlled operating theater. We are now routinely performing complex sedation in entirely different environments. Bustling emergency departments, incredibly tight radiology MRI suites, dental clinics, and endoscopy units. Each of these non-OR settings brings its own unique spatial and logistical challenges. Now, this is a concept you must absolutely internalize. Sedation in children is not a set of neat, isolated boxes. It is a fluid, incredibly slippery continuum. We classify it into 4 main depths: minimal sedation, or simply anxiolysis, moderate sedation, deep sedation, and finally, general anesthesia. Here's the catch. Due to their unique physiology, a pediatric patient can slip from an intended moderate sedation straight into deep sedation, or even general anesthesia in an absolute heartbeat. As that depth increases, you see a rapid deterioration in airway patency, spontaneous breathing, and cardiovascular function. The golden rule here? You must always be fully prepared and equipped to rescue a patient from at least one level deeper than you originally intended to take them. Section 2. Assessment and fasting. Preventing a crisis starts long before you even draw up a syringe. You need a rigorous, meticulous pre-procedural assessment. We're talking a full medical history, evaluating current medications, previous experiences with anesthesia, and any family history of adverse reactions. You must thoroughly assess the airway and assign an ASA physical status classification. Listen, if your patient has an ASA class of 3 or higher, or if they have anatomical airway anomalies, moderate to severe tonsillar hypertrophy, obstructive sleep apnea, or special neurodevelopmental needs, that mandates an immediate consult with a specialist anesthesiologist, period. And right before you start, run through your SOAPME checklist: suction, oxygen, airway equipment, pharmacy and drugs, monitors, and special equipment. Do not ever start a procedure without verifying every single one of those elements. Next up, let's talk about fasting, or NPO guidelines. For elective PSA, we adhere strictly to the general anesthesia fasting standards. This is generally the 1-4-6 rule. That means at least 1 hour of fasting for clear liquids, though some older guidelines say 2, 1 is becoming more standard, 4 hours for breast milk, and a full 6 hours for infant formula or solid foods. But we all know that in an emergency setting, time simply isn't always on our side, and a child might not meet these strict criteria. In those unfasted emergency scenarios, you have to carefully weigh the risk of aspiration against the risk of delaying a critical procedure. Interestingly, inhaled nitrous oxide can serve as a brilliant, exceptionally safe exception that we can often use even in unfasted patients. Section 3. Pharmacology and monitoring. Let's delve into the absolute core of our practice, our pharmacological toolkit. Let's start with ketamine. It's a dissociative agent that brilliantly provides both sedation and analgesia. Typical IV dosing is 1 to 2 milligrams per kilogram, or 4 to 6 milligrams per kilogram if you're forced to go intramuscularly. But watch out for vomiting, emergence delirium, and that rare but terrifying laryngospasm. It is strictly contraindicated in patients with a history of psychosis, significantly elevated intracranial or intraocular pressure, or severe cardiovascular disease. Then we have Propofol, lightning-fast onset and recovery. But remember, it offers absolutely zero pain relief. You'll typically use an IV bolus of 1 to 2 milligrams per kilogram, followed by an infusion. The massive risks here are injection site pain and profound apnea. Never use it in patients with severe egg or soy allergies or lipid metabolism disorders. Moving on to Dexmedetomidine. This is fantastic for non-painful imaging like CTs or MRIs because it provides sedation and very mild analgesia without causing respiratory depression. You give an IV loading dose of 1 microgram per kilogram, then maintain at 0.2 to 0.7 micrograms per kilogram per hour. Just keep a very close eye on the monitor for bradycardia and hypotension. For simple anxiety, Midazolam is incredibly reliable for amnesia and anxiolysis. It's versatile too. You can give it orally at 0.4 to 0.5 milligrams per kilogram, intranasally at 0.2 to 0.3, or IV at 0.1. Just be aware of potential paradoxical excitation, and remember you can reverse it with flumazenil. We also use nitrous oxide, typically at concentrations of 50% or less, for non-invasive, minimal to moderate sedation with a lightning-fast recovery. But be incredibly careful if you combine it with other sedatives, as that can unexpectedly plunge the child into deep sedation. Finally, Ketofol, a clever synergistic blend of ketamine and propofol designed specifically to cancel out each other's worst side effects. And of course, always be familiar with your non-IV routes like oral, intranasal, or rectal, which have different pharmacokinetic profiles but are absolute lifesavers when venous access is a struggle.
Now, administering those drugs is only half the battle. Monitoring is where you catch the complications. Standard vital monitoring, pulse oximetry, non-invasive blood pressure, heart rate, and sometimes ECG is your baseline. But let me be incredibly clear. If you are venturing into deep sedation, continuous end-tidal CO2 monitoring or capnography is the absolute gold standard. Why? Because if you are giving a child supplemental oxygen, pulse oximetry will look perfectly fine, completely masking hypoventilation until the child has basically stopped breathing. Capnography detects that respiratory drop instantly. This is especially non-negotiable in spaces with spatial constraints, like a dark, isolated MRI suite. Additionally, the bispectral index, or BIS monitor, can serve as a highly useful adjunct to objectively measure the depth of consciousness.
Section 4. Adverse Events Management.
Let's look at the hard data to put our risks into perspective. A massive 2025 systematic review and meta-analysis by Kahn and colleagues tracked adverse events in Pediatric Emergency Department PSA. Out of 1,000 cases, you'll see vomiting about 105 times, agitation 37.5 times, and hypoxia about 38 times. Apnea occurs roughly 8.6 times per 1,000, hypotension 9.3 times, and the need for bag valve mask ventilation sits at 13.5. Now, while it's true that ketamine and ketamine combinations carry a slightly higher risk for specific respiratory complications, here is the most reassuring statistic of all. Laryngospism is incredibly rare, and the number of cases escalating to actual endotracheal intubation was exactly 0. Literally 0.
That zero intubation rate exists because we are highly trained to rescue the airway. When you recognize respiratory depression or obstruction, you follow the PALS algorithmic steps immediately. Step 1, simple basic airway positioning, like a jaw thrust or chin lift. Often that's all it takes. Step 2, apply or increase supplemental oxygen. If the patient is still apneic, do not wait. Move straight to step 3, which is initiating effective bag valve mask ventilation. Only if BVM completely fails, step 4, do we escalate to a supraglottic device like an LMA or finally intubation. This stepwise rescue must be absolute muscle memory for your entire team, reinforced by regular simulation training. And then there is laryngospasm. It is rare, but it is one of the most daunting, high adrenaline complications you will ever face. When the vocal cords clamp shut, your immediate response must be rapid, forceful, positive pressure ventilation with 100% oxygen. If the spasm doesn't break, you actually need to deepen the sedation, usually with a fast push of propofol. Still locked tight? You must instantly call for help and administer a muscle relaxant, typically succinylcholine, alongside atropine to prevent severe bradycardia, to physically paralyze and open those vocal cords. You literally only have seconds to act, which is why preparation is everything. Section 5. Personnel and Safety Guidelines. Safe sedation is never a solo act. Systemic safety relies entirely on the right personnel. The clinician directing the sedation must possess incredibly strong airway management and advanced CPR skills. PAL certification is the bare minimum. Crucially, if you are providing moderate or deep sedation, you cannot do the procedure and monitor the patient simultaneously. You must have an independent, dedicated observer in the room whose sole clinical responsibility is continuously monitoring the patient's vitals and depth of sedation. Furthermore, at an institutional level, it is highly recommended to form a multidisciplinary sedation committee, ideally spearheaded by anesthesiologists, to establish strict credentialing programs and mandate regular, ongoing safety training.
Looking at localized adaptations, it's worth examining the 2024 Korean Pediatric PSA guidelines developed by the Korean Society of Anesthesiologists. These guidelines brilliantly address 15 core clinical questions, covering everything from provider qualifications and drug selection to high-risk specialist referrals, fasting rules, and complication management. However, these guidelines also impartially and frankly acknowledge a very harsh clinical reality. In many severely under-resourced, bustling domestic emergency departments, securing an independent, highly trained monitoring clinician separate from the proceduralist is a massive logistical hurdle. It highlights the incredibly difficult tension between ideal academic standards and practical, on-the-ground staffing constraints.
Section 6. Discharge and Quality Improvement.
Once the procedure is done, we cannot just quickly send the patient home. Discharge requires strict, objective, standardized criteria. The child's cardiovascular function and airway patency must be completely stable. They must have fully regained consciousness with entirely intact protective airway reflexes. Nausea, vomiting, and pain must be fully controlled, and they need to be well hydrated and capable of age-appropriate mobility and speech. A fantastic tool for this is the Surrey Memorial Hospital Discharge Score. It evaluates activity, breathing, circulation, and consciousness on a 0 to 2-point scale each. A patient absolutely must achieve a total score of 7 or higher before they are cleared for a safe discharge.
But our responsibility doesn't end at the hospital doors. Post-discharge caregiver education is your final, critical safety net. You must provide clear written instructions detailing dietary progression, activity restrictions, and emergency contact numbers. For infants, you have to explicitly warn parents about car seat risks. If a sedated infant's head slumps forward during the drive home, their airway can completely obstruct. Therefore, an adult must sit in the back seat to actively monitor them. And here is an absolute non-negotiable rule. Preterm infants under 60 weeks corrected age carry a massive, well-documented risk of delayed apnea following sedation. You never discharge them on the same day. They strictly mandate overnight, continuous hospital monitoring.
To truly evolve and optimize your institutional practice, you cannot rely on gut feeling. You need robust data. Enter TROOPS, which stands for Tracking and Reporting Outcomes of Procedural Sedation. It is a brilliant standardized tool for meticulously auditing adverse events. Instead of just guessing that your department is doing fine, implementing a system like TROOPS provides your multidisciplinary committee with hard, undeniable data. This allows you to track complication rates over time, identify systemic weaknesses, and drive incredibly effective, continuous quality improvement across your entire hospital. As we wrap up this clinical explainer, I want to leave you with a deeply pragmatic question to ponder. Considering the undeniable gap between the rigorous academic guidelines we've discussed today and the daily, harsh reality of localized staffing and resource constraints, how can your specific institution practically leverage standardized reporting systems, like TROOPS, to bridge that divide? Remember, true pediatric safety isn't just about executing perfect pharmacology in the moment. It is about building perfect, resilient clinical systems that protect the child long before and long after the procedure. Thank you so much for your time and dedication today.